So it's a huge topic. Okay. Vitamin D, vitamin D, rickets and metabolic bone disease, osteomalacia, it's a huge topic. This is not only important for orthopedics, this is equally important like for pediatrics, medicine, like this. So, uh, like vitamin D deficiency conditions like rickets and osteomalacia, they have different etiologies, various causes. Rickets, this happens because the most important thing in pathogenesis is defective mineralization. Okay. So the rickets happens in the children before the growth plate fuses, and the osteomalacia happens seen in adults. Okay. So before we proceed, we have to know the basic function, basic role and metabolism of vitamin D. So it is kind of a superfood. You know, vitamin D is not only important for bone, it is important virtually every cell. In body they have vitamin D receptor, and it is important for various other functions, immune functions and normal functions of like other cells. So to start with, the body cholesterol, they go to the skin, and this is in the skin, they transform into 7-dehydrocholesterol. Okay. So under the photosynthesis, it happens in the skin. So under sunlight, it converts to the pre-vitamin D3, that is the cholecalciferol. Okay. So this is not the active form of vitamin D. The next step is it goes to the liver, and there is one enzyme called 25-hydroxylase. It is hydroxylized and then converted to 25-hydroxy vitamin D. Okay, this is the circulating form, but this is still not the active form. The final activation occurs in kidney. It goes to the kidney where it is converted to 1,25-dihydroxy vitamin D, that is the calcitriol. So this is the active form of vitamin D. Okay. So in body with the photosynthesis, it goes through different steps, first in liver, then in kidney, and then converted to active form of vitamin D. So, and kidney is the main source. This active transformation happens in other organs also. So the most important thing is sun exposure, ultraviolet B radiation. Okay. So you get the ultraviolet B during the peak hours when the sun is at the peak, around mid-noon or around after 11 a.m. But you have to remember that this is also the culprit for the skin cancer. Okay. So people are using sunscreen, but sunscreen it negatively impacts vitamin D synthesis. Okay. So you have to keep in mind. So vitamin D is not only important for bone, it is virtually related to numerous disease, from cardiovascular disease, diabetes, autoimmune conditions, inflammatory bowel disease, any other skin disorders. So any kind of chronic disease, they have directly or indirectly vitamin D plays some role in this kind of chronic conditions. So you have to know the requirement of vitamin D. In infant, it is usually 400 international unit, and in adults it is usually 600 international unit, the recommended dietary allowance. Okay. And the source of vitamin D, usually the food, you get vitamin D through animal proteins, cod liver oil, salmon fish, tuna fish, and importantly in most of the countries, the milk and other yogurt, they are fortified with vitamin D. So you need to get some adequate exposure of the sunlight so that your body without diet, your body gets adequate amount of vitamin, the recommended daily dietary allowance in your body. And those living in like winter and where the sun exposure is limited, you have to get some kind of supplement along with some calcium supplement to make up for the loss. So the rickets and osteomalacia, very two important conditions, kind of similar conditions. The basic pathogenesis is defective mineralization. Because of the lack of vitamin D, there is a calcium and defective calcium phosphorus metabolism. So there is a defective deposition of these minerals in the bone matrix. Okay. So the manifestation is different because in rickets they usually manifest in children before the fuse of the growth plate, and osteomalacia in adults. So this is the disease of the growing skeleton. So it happens before the growth plate fuses. Okay. So what it does, since there is a defective mineralization, the bone becomes soft and it impacts the growth plate. You know the anatomy of bone. What happens? At the end of the bone there is a growth plate, that is the physis, metaphysis, physis and epiphysis. So the growth happens with this region. In the physis there is a different zone. The cartilage cells, they grow, they hypertrophy, and then they produce the bone matrix and they got mineralized. So this area got this area is the main part of the bone that is affected with rickets. So before we move, we have to know the recommended daily requirement of calcium. In adults it is 400 to 500 milligram and phosphorus is 1000 to 1.5 milligram. So there's various kind of, it has a diverse etiology. It could be nutritional because of the inadequate synthesis of vitamin D, or inadequate intake of the vitamin D, or maybe inadequate absorption of vitamin D. So nutritional rickets it could be the vitamin D resistant rickets. Now you remember this entity, second entity, is the most common cause of non-nutritional rickets. So the most common is nutritional rickets, usually seen in like Middle East, Asian countries, in our country, and African countries, where there is still nutritional deficiencies predominant. But in like more developed nations like Europe, or if you move to US or UK, so they have a very rare incidence of rickets. So I will share you with a funny incident. So it is basically still it is a disease, it is a problem in our country, Middle East, African nations. And this entity, vitamin D resistant rickets, it is the most common cause of non-nutritional rickets. Okay. And there are other genetic causes like vitamin D dependent rickets type 1, vitamin D dependent rickets type 2, and other causes like renal rickets and some other entities. So the vitamin D deficiency could happen because of the nutritional problem, because of the dietary deficiency. It could be intestinal malabsorptions. It could be because of the lack of exposure to sunlight, and any kind of chronic renal or liver failure, liver disease. As you know, it gets metabolized in liver and kidney. So any kind of chronic problem, you have this kind of vitamin D related problem issues. And any like related oncogenic issues like soft tissue or tumors. So sometimes because of soft tissue tumors, we have problems with vitamin D, and you have to remember this thing. We have drug induced reasons for vitamin D deficiency. What are the drugs? The most common culprit is anticonvulsant medications. What are those? Phenytoin, you have read in pharmacology, phenytoin, phenobarbital, and maybe carbamazepine. So very often you get this kind of question, NEET PG. You have to remember this thing. Okay. And genetic causes, vitamin D dependent rickets type 1 and type 2. You can remember this thing. Type 1 is because of the problem in the kidney. There is a deficiency of the 1-alpha hydroxylase, and type 2 is the problem with the receptor. So the vitamin D cannot act on the cell. And vitamin D resistant rickets, as I told, this is the most common cause of non-nutritional rickets. So it is often called familial hypophosphatemic rickets. So I will get back to you later on. Sorry. So before I, you know the pathogenesis, to understand the pathogenesis. So this is the end of the bone. This is the metaphysis, this is the physis, and this is epiphysis. Okay. So this is the growth plate. Okay. So this end is toward the metaphysis, this is the physis. So you see, on the epiphyseal side, this is the germinal zone. Okay, the stem cell, immature cells, they proliferate. They proliferate and they got matured in the hypertrophic zone, and they produce the matrix. And towards the metaphysis, there is a zone of provisional calcification. So in rickets, what happens? This part is not mineralized. So the cells are getting produced, they are getting proliferate, they hypertrophy, they got piled up, but they are not, they produce matrix, but they are not getting mineralized. So they produce soft bone. Okay, like it is not the normal bone. It is a, the problem is the quality of the bone. So because of this pathogenesis, now you will understand why we get this kind of changes, because skeletal changes are very important, you have to remember. Okay, you get lots of questions in viva examination, in your theory. So why we get this kind of changes? Since if you remember this slide, then you will understand the changes. Why? So as I told, it affects the deeper layer of the physis where there is zone of calcification. Okay. So what happens in the proliferative zone? There is active cells. The cells are irregular, disorganized, they are piled up, and in zone of calcification, it is poorly mineralized because of the defect, inadequate vitamin D. It could be vitamin D loss or vitamin D deficiency, or vitamin D cannot act because of the resistance. So what happens? They produce bone that is, soft, that is not strong enough. So what happens with the load? The load is applied, naturally they will deform. This metaphysis part, this part will deform. Okay. So the cells, this part is getting, they produce the, because of a lack of mineralization, the bone is soft, and so naturally this metaphysis will deform. So what you will get in X-ray? Metaphysis is broad and cup shaped. Okay. Cupping of the metaphysis. Okay, and metaphysis widens. So this is the normal part, if it is a distal radius, and this is the epiphysis, and you get this metaphysis cupping. So load means it could be like any kind of load because of the muscle tension also, or any physical load. So this cupping of the metaphysis, very important, you get questions with this. So the metaphysis is broad. Okay, see, it's very broad compared, this is not the normal thing. It is hazy. And vitamin D is not only for bone, it is also important for other functions of the other skeletal part. So you get muscle weakness, the child is generally irritable, lethargic, and since with the vitamin D deficiency you get calcium deficiency, so sometimes this tetany, convulsion or seizures, they happen because of the calcium deficiency. Okay. And this important thing you have to remember again, we get frontal bossing. Bossing is the prominent frontal bone. The same thing, the bones are soft, so it gets prominent. There is a delayed closure of fontanelles. Okay. The same thing because of the defective mineralizations. And skull bones are thin and soft, it is called craniotabes. What happens if you push the skull bone, it is so soft, like it will go inwards and then bounce back. This is called craniotabes. These are the important features, clinical features you will get to see in full-fledged rickets. Other more important findings, you get rachitic rosary. What is this? We have this costochondral junction. Okay, so in the same pathophysiology, this costochondral junction, this is a growing part. So you get this kind of beads, rounded beads in the costochondral junction. So it will appear as a string of beads, a string of rosary. So it is called rachitic rosary. You get Harrison groove. What is Harrison groove? You see this kind of, this is a, the part of the rib cage around 6th or 7th rib, it goes inwards. Why it happens? If you remember the mechanism, then it will be easier to remember, because around the 6th or 7th rib we have the attachment of diaphragm, right? So the rib cage is soft, it gets pulled inside. So you get this kind of groove. It is called Harrison groove. Pectus carinatum, Pigeon chest. The chest is like narrow, it is protruded anteriorly. Okay. So you get pectus carinatum. So because of this, all this problem, there is thoracic asymmetry. Because of chest problem, there is a decreased lung capacity. It could lead to respiratory infection and other things. So these are all important findings, all important clinical features you have to remember throughout your life. And I would like to point to you, we get similar kind of like beads in other condition. What is this? Do you know? In vitamin C deficiency, in scurvy, we get scorbutic rosary. What is this? So how do you differentiate between rachitic rosary and scorbutic rosary? So in vitamin C scurvy deficiency, scurvy, these beads are like more angular. It is rounded. In scorbutic rosary, they are more pointed, painful. And in vitamin C deficiency, you get gum bleeding, other dental findings. So they will help you to differentiate between whether it is because of the vitamin D deficiency or vitamin C deficiency. Abdomen, because the muscles are lax, soft, the abdomen gets protruded, you get pot belly. And spine, whole skeletal system is, gets affected. You get kyphosis, scoliosis. And in pelvis, I will show you the picture later. So the pelvic bone is get deformed, and the inlet, pelvic inlet, it is narrowed. Extremities, since it affects the growing part of the bone. What are the, most commonly you get those finding in proximal humerus, distal radius ulna, knee joint, distal femur, proximal tibia, distal tibia. So if there is a growth disturbance, so you get this kind of angular deformity. It is called bored leg, genu varum. Okay, you could also get genu valgum, knock knee. So valgum or valgus or varus deformity. This coxa vara, a similar finding coxa vara is in the hip. Okay, the neck is in varus. So the hip joint could be affected. The tibia, it could be bored. And if you examine the child, you will find since I told you, the metaphysis is widened. So the joint, the end of the bone, they are widened. Okay, so you get the wrist joint, ankle, they are all like, it's not, you will differentiate. This is not normal, this is like widened. Other findings, because the bone is weak, you get fractures. This is a pathological fracture. It is incomplete fracture. We call it loser's zone. You will get to see the incomplete fracture line, radiodense line. Growth restrictions, delayed dentition, the teeth also is affected. Okay, and these hypocalcemic symptoms like tetany seizures. Okay, they are quite common in a florid rickets. So again, to recapitulate, scoliosis, this frontal bossing, the tibia is bowed, and pot belly. These are very important to remember. See the rachitic rosary. All the beads, they are like a string of beads along the costochondral junction. Okay, the sulcus, along the diaphragmatic attachment around the 6th or 7th rib. The pectus carinatum, the chest wall is, the sternum is protruded anteriorly. Okay. So the diagnosis, you start the diagnosis, it is like in a rickets, it is clinically naturally evident from the clinical findings. Okay, so you take the history, you start with the history, you ask the mother or take the dietary history. So also you get the history of some exposure, whether any other risk factor is present or not, any drug history, whether mother is taking on drugs or not, malabsorptions or any kind of chronic disease, renal disease or liver disease. So you assess the clinical signs and symptoms. They are generally pathognomonic of rickets. They are kind of enough to diagnose the whether child is getting having rickets or not. Radiological changes. I have told you, showed you the changes. So the earliest changes are seen in the lower end of the radius and ulna, okay, in the wrist, and the laboratory test and bone biopsy. So X-ray, this is, these things, these are quite complex, but I will mention only the salient points. So in acute stage, the bones are, metaphysis is broadened, it is broad, soft, epiphysis is like hazy. When it is established, it is like broader, more ragged. There could metaphyseal cupping and fraying. And when there is a, when you treat the rickets, so you get this kind of dense line at the end of the metaphysis. Okay. When you address the conditions, when you start the therapy, and if the child responds to the therapy, then there is a, this is the healing sign. Okay. It is called Frenkel's line. Along the metaphysis, you get this dense line. And the fourth is completely repaired. All the skeletal changes, they gradually resolve to normal. In laboratory findings, since the vitamin D, they maintain calcium and phosphorus homeostasis. So with the deficiency of vitamin D, you get calcium level is generally low, or it could be normal also. But phosphorus level is typically reduced. There is a, because of the, now, with calcium deficiency, what happens? With the vitamin D deficiency, calcium deficiency, there is a feedback pathway. There is a increased production of the parathyroid hormone, PTH. So parathyroid is released. What is the function of the parathyroid? It increases the bone turnover. So this alkaline phosphatase is elevated. So you get the low calcium, low phosphorus, and because of the increased bone turnover, you get high alkaline phosphatase. So the bone production is okay, bone production is normal or maybe increased, but bone is not getting matured or mineralized. That is the basic problem. So vitamin D is deficient naturally, 25 hydroxycholecalciferol, and urinary calcium could be lowered. Now treatment, naturally you have to address the cause, whether it is because of nutrition or because of some other issues. So in nutritional rickets, you ensure that the patient is getting adequate sunlight, and along with that you have to ensure to make sure that adequate supplement of dietary vitamin D, and you have to start the Strauss regimen. So Strauss regimen is basically, the principle of the Strauss regimen is you start with the high dose of vitamin D to, it is like a bolus dose of vitamin D to address the deficiency, then gradually maintain the dose. So initially you start with the 6 lakh international unit as a single injection, and then assess whether it is responding, the patient is responding or not. Usually it takes 2 to 4 weeks to see any response. So after you get the X-ray, you see whether this line, the healing line, is appearing or not. If it is not responsive, you again give a repeat injection of the 6 lakh international unit. If the child doesn't respond in second dose, then that is kind of a confirmation that he is suffering from some kind of refractory rickets, some kind of genetic rickets, or this vitamin D resistant rickets. Okay. And if the patient responds, then you maintain the dose with a maintenance dose around approximately 400 international unit is given till the healing. Okay. So this is this regimen you have to remember. This is very important. In pediatrics also you read this regimen, and for your for your life basically, you have to remember this thing. This is very basic. So it takes around 2 to 4 weeks for the X-ray evidence to appear. Okay. Once you administer the bolus dose, then wait for the 2 to 4 weeks to see the healing sign of rickets. And then in the meantime, you ensure that the baby is getting adequate sunlight, adequate dietary supplementation. One thing to remember, rickets is quite rare before 6 months of life, but it is usually seen after 6 months, usually 6 to 3 months. Can you tell me why it is rare before 6 months? Because before 6 months, the baby is, it is quite rare to have vitamin D deficiency. The baby gets vitamin D through the placenta, through the breast milk. But after 6 months, if the, breast milk is not the adequate source of vitamin D. Okay, so if you are not, giving supplement of vitamin D, so after 6 months, the baby might develop vitamin D deficiency. So right now, like after every children, it is now recommended to start vitamin D supplement immediately. So this dense metaphyseal line of calcification. Okay. So after after you start the therapy, and within 2 to 4 weeks, if you get this line, this is called Frankel's line. Okay. That means the calcium is getting deposited in the zone of calcification. That means mineralization is getting normal. So we get this line. And other orthopedic treatment. So for the mild deformities, it is usually sometimes respond to conservative treatment like some kind of splinting, and they sometimes heal spontaneously. But those with severe deformity, for instance, bored leg, genu varum, genu valgum, they need some kind of treatment. So I forgot to mention, it is not only osteotomy. We have osteotomies for severe deformities. So currently we have other treatment, like we call it growth modulation. Modulate the growth of the physis. Whether the outer side is growing more or inner side, we modulate the growth. And if a child is older and the deformity is more severe, then we have to do some kind of osteotomy to correct the growth. But remember, do not do any kind of surgical treatment before 6 months of starting medical treatment. Since the bone is, the quality is poor, so you get kind of complication, non-union or other kind of thing. So I will mention only briefly. Just remember this kind of entities. These are vitamin D dependent rickets. They are more resistant to treatment, usual treatment. So these are genetic causes of rickets. So there are two vitamin D dependent rickets. One is type 1. Type 1 is basically deficiency of 1-alpha hydroxylase in the kidney. So the kidney is not producing the active form of vitamin D. Okay. So the patient needs lifelong treatment with the calcitriol, that is 1,25 hydroxy vitamin D. And what is type 2? Type 2 problem is the vitamin D receptor defective. So there is adequate amount of active form of vitamin D in the body, but it cannot act on the target cell. So this neither vitamin D or any kind of metabolites is curative, because the receptor is problem. The problem is with the receptor. So then patient needs long-term treatment with the calcium. And these vitamin D resistant rickets, again I will ask you to remember, it's often called familial hypophosphatemic rickets. It is the most common cause of non-nutritional rickets. It could be X-linked dominant or autosomal recessive or dominant, but the most common is X-linked dominant. Okay. The neat question. This is most commonly X-linked dominant. So what is the basic problem with this? The basic problem is the absorption of the phosphate in the kidney, and with or without some problem with the conversion of the 25 hydroxy vitamin D to active form. Okay. So it is most commonly because of the deficiency of the phosphate. That's why hypophosphatemic rickets. So it respond to vitamin D, but we need higher dose of vitamin D. The clinical features are more severe. The patient is like dwarf. There is a more severe deformities. It is called wind-swept deformity. That means one side is in varus, one side is in valgus. Yeah. So patient is short stature, combination of various deformities in the extremities. There is and there is generally ligamentous instability and laxities and other deformities. You get the similar radiological finding and laboratory finding. The calcium could be low or normal because it is because of defective absorption of phosphate in the kidney, so the phosphate level is low. And interestingly, though the blood phosphate is low, but you get phosphatidyluria because of the defective absorption. So these are important laboratory finding in hypophosphatemic rickets. And briefly, you have to know what is the difference between rickets and osteomalacia. They are basically, the basic pathology is same. The bone is weak since there is a defective mineralization. But the osteomalacia is seen in adult after the growth plate fuses. So the bone content is not mineralized and it is being replaced by the soft osteoid bone. So it is common in people who have lack of sun exposure. It could be because of dietary deficiency of vitamin D, any kind of malabsorption, or any kind of surgery like gastrectomy, or during pregnancy, or any kind of chronic kidney or liver disease. The clinical features are like diverse. It starts with the bone pain along with the muscle weakness. Since the bone is weak, you get spontaneous fracture, that is pathological fracture, and along with some problem with the deformity in the spine. These are the important radiological findings you get in osteomalacia. So the bone quality is poor, so that is bone is like you get it is not dense properly. You get looser zone. What are these? These areas, they are incomplete fracture. Okay, incomplete pathological fracture. So they are spontaneous. You get pelvis deformity. We call it triradiate pelvis and protrusio acetabuli. What are these? Since the bone is weak, so with normal loading, what happens? The acetabulum is weak. So with normal loading, this goes inward. The femoral head is protruded inward. It is called protrusio. And triradiate means the inlet is deformed. It is like a three-pronged appearance of the inlet. So it is called triradiate pelvis. So these are important clinical X-ray findings of osteomalacia. You get codfish vertebra, biconcave appearance of the vertebra, because of the same thing, the low bone quality. In laboratory examination, you get serum calcium is low, serum phosphate is low, and alkaline phosphatase is high. And if these clinical findings, this radiological features, they are diagnostic most of the time, and you confirm the diagnosis with the bone biopsy. So in bone biopsy, what you see adequate amount of the bone matrix, osteoid, but they are not mineralized. The treatment is same. You give vitamin D supplementation and calcium supplementation, and importantly, you treat the underlying cause. If you do not address the underlying cause, it is not going to help the patient.